Uncertainty after diving. Case reports and recommendations by Marty McCafferty. A 53-year-old man was diving at a resort in the South Pacific. He was doing approximately 4 dives per day. All his dives were on air, and all were within the computer's no-decompression limits. In the evening of the 3rd day, approximately 3 hours after his last dive, and a half hour after dinner, he began to experience severe abdominal pain. The pain radiated to his back just below the right shoulder blade. He vomited several times, felt weak, and needed assistance walking. Concerned about the possibility of severe decompression sickness, his friends called a taxi and rode him to the local hospital. Some things about this diver's symptoms and recent history suggest decompression sickness, and most doctors would include it on their list of differential diagnoses. The evaluating physician in this case did consider it, but he knew that other potential causes had to be eliminated first. After a cardiovascular emergency was ruled out, blood tests and ultrasound imaging of the diver's abdomen revealed stones in the gallbladder that were causing acute inflammation. The diver underwent laparoscopic surgery and made a successful recovery. So how does this relate to symptoms of decompression sickness? Well, books and articles about decompression sickness usually include an extensive list of signs and symptoms. But it is important to remember that none of the signs and symptoms in any of these lists is exclusive to decompression sickness. In other words, symptoms related to decompression sickness may also be present in other conditions. The most common symptoms of decompression sickness include headache, lightheadedness or dizziness, nausea, joint or muscle aches, fatigue, severe lethargy, or generalized weakness. As you can see, these symptoms can apply to a wide range of medical conditions, not just DCS. This makes diagnosing DCS a challenge. Here's another example. A 48-year-old woman was completing a dive to 30 meters for 25 minutes on 32% nitrox. About 10 hours after surfacing, she began to experience widespread but intense muscle pain. She couldn't find a comfortable position to lie in, and nothing seemed to offer relief. She called the emergency medical services, and they transported her to the local hospital. While discussing the possible diagnosis, the doctor found out that the woman had begun taking statin medication to lower her cholesterol 3 weeks before. Muscle pain is a rare side effect of statins, and blood test results suggested that muscle pain is a rare side effect of statins, but blood tests showed that her pain was most likely due to the medication. Nevertheless, the hyperbaric physician they consulted did not want to dismiss the possibility of decompression sickness, and the diver was treated with a standard US Navy treatment table 6. The hyperbaric treatment had no effect on the symptoms and confirmed the likelihood that the muscle pain was due to the medication. The take-home message is that whenever you begin to take a medication, whether this is prescription or over-the-counter, make sure to familiarize yourself with the potential side effects. As this case illustrated, the side effects of some medications may mimic decompression sickness. Medications can also affect your ability to function normally, regardless on whether you're on land or underwater. Common seasickness medications, for example, come with some advisories stating that they may cause drowsiness. Physicians trained in dive medicine typically recommend waiting at least 30 days after starting a new prescription of medication before going back to diving. Similarly, divers should always try non-prescription medication well in advance of diving, so they will know how the drugs affect them. In addition to limiting the risk of disorienting or otherwise hazardous side effects at depth, this recommendation also helps reduce the risk of confusing the medication side effects with decompression sickness. Diagnosing decompression sickness can be challenging. It is a relatively rare condition, and there are no lab tests to confirm or rule it out. It shares signs and symptoms with many other illnesses or injuries. Divers who have pre-existing musculoskeletal issues such as spinal problems, arthritis, or residual effects of previous trauma can be particularly susceptible to this diagnostic uncertainty. The physical stresses and activities associated with diving and travel, such as carrying heavy equipment, enduring uncomfortable sleeping or travel accommodations, swimming against currents, or experiencing rough boat rides, can all aggravate existing conditions. Strains, sprains, and overuse injuries that occur in the absence of diving are relatively easy to diagnose. But as soon as diving is involved, a doctor might reasonably consider the possibility of decompression sickness, which then brings the costly and time-consuming issue of undergoing hyperbaric treatment to stay on the safe side. Musculoskeletal problems, whether pre-existing or not, may manifest as pain, numbness, or loss of strength and reduction of mobility, all of which may resemble decompression sickness. The key to learning the true cause of such symptoms is a thorough review of the diver's medical history and the circumstances surrounding the complaints. Dan Medical Services often receives calls from divers who've traveled to tropical or subtropical destinations and are now experiencing severe headache, multiple joint aches, abdominal pain, nausea, and general malaise, often developed a few days after diving. With no additional information, it might be easy to conclude that these were the result of decompression sickness. However, further inquiry often indicates fever or diarrhea, suggesting that this is a tropical disease rather than decompression sickness. When fever, but not vomiting or diarrhea, is added, then dengue or other tropical virus infections and malaria may need to be considered. People with these symptoms may require prompt medical attention, but not evacuation for recompression. They need the right medical care. Excluding decompression sickness is generally a process of ruling out other causes. It is imperative that we don't discount the possibility of other potential non-diving related injuries or illnesses. Just because someone has been diving does not mean they are immune to everything else. This also does not suggest that we should discount the risk of decompression sickness. When a person has been diving, decompression sickness absolutely needs to be considered in the physician's differential diagnosis. To illustrate this, a 46-year-old male diver on a week-long dive trip on a liveaboard vessel was doing 4 to 5 dives per day. All the dives were well within the recommended recreational no-decompression limits. The deepest dive depth was set to 27 meters, which was his first dive on the 3rd day. The next morning, the diver complained of right shoulder discomfort. 5 years earlier, the diver had had surgery on that shoulder to repair a torn rotator cuff. Since surgery 5 years prior, he had done more than 80 dives with no problems, but it was not uncommon for him to experience discomfort in that shoulder with exertion or certain activities. Usually he could find a position of comfort, apply ice, or take ibuprofen to relieve the discomfort, but this time the symptoms were somewhat different and not easily relieved. The diver's companions believed that the symptoms were due to the previous medical history because they had all dived the same profile and had not developed problems. When the diver eventually reported his symptoms to the boat crew, they provided him with high-flow oxygen. Based on the fact that the symptoms were different from the typical ones, the captain diverted the ship towards an island with a dive clinic. After breathing oxygen for about half an hour, the diver reported some improvement, but not much. The ship arrived at the island half an hour later, and the diver was taken to the clinic. The physician on duty evaluated him and discovered that the right arm, his dominant arm, was also significantly weaker than the left. Decompression sickness was diagnosed, and the diver was treated on a standard US Navy treatment table 6, which provided measurable improvement. Because the symptoms did not completely resolve, the doctor treated him again the next day on the shorter US Navy treatment table 5, which brought about complete resolution of symptoms. There is controversy regarding the potential for increased risk of decompression sickness at the site of a previous injury, and there's little scientific data addressing that issue. But, controversy notwithstanding, there are certainly cases of individuals with pre-existing musculoskeletal problems who chose to dive and developed symptoms that resulted in diagnostic confusion. If you or your dive buddy has such issues, it is imperative for both of you to know what the other person's usual state looks like. Before diving, discuss any existing pain or movement restrictions, weakness, or other information, so that there is a definite baseline. Communicating information about a diver's normal state can be of great value. Any variation of symptoms from previous experience demands assessment, but does not by itself constitute a definitive diagnosis. Divers with these sorts of problems should regularly get detailed neuromuscular examinations by a doctor. After a dive is no time to discover a neurological deficit that may or may not have been there before. Here is another example of how difficult it can become to make a diagnosis of decompression sickness. A group of friends in their early 30s were on a dive vacation on a Caribbean island. They did 4 dives on their first day, with the first dive being to 24 meters, the next to 18 meters, and shallower. They waited at least an hour between dives, breathed air, and had bottom times that all were well within the dive computer's no decompression limits. All the dives were uneventful. The group went out to dinner and drinks that evening. The next morning they met for breakfast prior to boarding, and a 33-year-old male member of the group was found absent. The roommate reported that when he left, the friend was in the bathroom and was expected to join the group later. After eating, the roommate and the 2 others went to fetch their friend. They found him in bed looking pale. He complained of severe headache, nausea, weakness, and feeling totally out of it. The headache was severe enough that he was light sensitive. He also reported vomiting once or twice. The group decided to take him to be evaluated at the local clinic because they had been diving and were concerned about decompression sickness. The diver had a slight stagger when walking, but required no assistance. The clinic was a 5-minute cab ride away from the resort. The physician on duty and her assistant obtained the diver's vital signs and conducted a neurological examination. The physician also obtained a history of events. The diver denied any symptoms prior to going out for the evening. He admitted that the events following dinner were not clear to him because he had consumed a lot of alcohol, which his friends confirmed. The physician ordered the administration of IV fluids, paracetamol, meclizine, which is an anti-nausea medication. The doctor also instructed the individual to avoid diving for the next 24 hours and return to the clinic if he did not improve. The diver rested and was able to eat and drink, non-alcoholic beverages that is, over the course of the day, and he felt much better by that evening. The next morning, he was feeling his old self and resumed diving with no further issues. The take-home message is this: having a good time on vacation is obviously part of the experience, but overindulging in alcohol during a diving vacation is unwise. There is suspicion that alcohol consumption before or after diving can contribute to decompression sickness, but more importantly, the after effects can easily be confused. Many divers in similar situations have needlessly undergone hyperbaric treatments. In conclusion, the signs and symptoms of decompression sickness are not exclusive to that condition only. However, when a person experiences signs or symptoms after diving, DCS is very often presumed to be the diagnosis. This is not bad because it does encourage the divers and staff to administer oxygen and ensure that the injured diver gets prompt medical care. But it becomes a problem when divers refuse to accept alternative explanations and become fixated on the need for recompression at the expense of other diagnostic or treatment modalities. In addition, the diversion of a non-diving related emergency from appropriate medical treatment for unnecessary recompression, especially by air late at night, can induce additional risks to the patient as well as the aircrew. There are many medical conditions that are much more serious than decompression sickness and for which timely treatment is critical. In the event of symptoms after diving, always provide oxygen first aid and get the injured diver to the closest medical facility. Don't hesitate to call the emergency medical services or the DAN emergency hotline. Tell the doctor that the person has been diving and encourage him or her to contact DAN for consultation. But keep in mind, there are more dangerous ailments than decompression sickness, and some of these must be considered first.